Good morning, consultant, senior registrars, medical officers present. I am Dr. Evelyn Mentor, resident of family medicine, presenting acid-related gastrointestinal disorders. I'll be discussing this under the following outline: preamble, introduction, gastroesophageal reflux disease and management, peptic ulcer disease and management, gastric erosion from NSAIDs use and management, Zollinger-Ellison syndrome and management, role of family physician, conclusion and referencing. Catastrophe have always been a problem to mankind. An example of the record of such affliction is available even in the New Testament era, where Apostle Paul made a prescription of a little wine for the stomach's sake to his young evangelist, was Timothy. So primary care is evidently the territory of family physician, and acid peptic disorders constitute a major concern in virtually every and all age bracket and gender. By way of introduction, acid peptic disease disorder are a wide range of conditions resulting from damage to the gastrointestinal tract mucosa as a result of acid and peptic activity of gastric secretions or reflux of its contents. There are fairly common health problems in primary care. The medical cost of treating peptic ulcer disorders run into billions of dollars annually, and this is caused by disruption of the balance between the mucosal defense, that's the defense that is covered by prostaglandins, their bicarbonate and microcirculation, and balance between those forces and the aggressive forces, which are the acid, pepsin, H. pylori bacteria, and drugs. And this is the mechanism of which ulcer is being formed. Advances in medicine has led to an improvement in treatment, and there are various treatment options available. What are the types of acid related GI disorders? We have gastroesophageal reflux disease, which is also called peptic esophagitis, gastric ulcer, duodenal ulcer, gastritis, duodenitis, gastroduodenitis, gastric erosions from NSAIDs, Zollinger-Ellison syndrome as stress related ulcer. For the purpose of this discussion, we'll be taking about 4 or 5 types of acid related disorders that are mostly seen in our primary healthcare practices. So we'll start with gastroesophageal reflux disease disorder. It is a condition which develops when the reflux of the stomach content causes troublesome symptoms and or complications. It occurs 2 to 3 times. It is 2 to 3 times more common in men than in women, and about 25% of adults experience heartburn in their lifetime, with 5% of people having daily symptoms. We have moderate to severe esophagitis, which is found in 8% of the global population, and in Nigeria, the prevalence rate of gastroesophageal reflux disease is about 32.8%. Etiologically, the risk of developing gastroesophageal reflux disease is associated with increased intra-abdominal pressure, reduced lower esophageal sphincter tone, pregnancy, obesity, and tobacco smoking. Other etiological factors include excessive alcohol intake, as seen in alcoholics, drugs like calcium channel blockers, nitrates, tricyclic antidepressants, and anticholinergics, and of course, hiatus hernia. So this is a diagram showing the causes of increased exposure to the esophagus from the gastric reflux. Here we see the first one here is defective esophageal clearance. When there's a reduced esophageal clearance, there will be persistence of food particles that are supposed to travel down to the stomach. They will remain in the esophageal lining, thereby causing reflux. Then we have the lower esophageal dysfunction, which is mostly common, where the sphincter is lax or loose and it does not close. So when patients take some positions, the acid content from the stomach tend to reflux back into the esophagus, thereby giving them this reflux. Then there is hiatus hernia. Then there is when there is a delayed gastric emptying, the stomach will be full of or already digested already churned food, So the food can definitely flow back into the esophagus, then also increase intra-abdominal pressure. Then what are the symptoms? Symptoms of gastroesophageal reflux disease are either specific and non-specific. The specific ones are heartburn, which occurs in majority of the patients, retrosternal discomfort, water brush, and odynophagia, also known as throat pain. The non-specific symptoms are either cardiac or respiratory. The cardiac symptoms is basically chest pain. We usually know it has no relationship with exercise. The respiratory symptoms are hoarseness of voice, also called Cherry-Donner syndrome, wheezing, chronic cough with features of lung abscess, interstitial pulmonary, and or laryngitis. Then the other respiratory symptoms include lump, they feel lump in the throat, persistent throat clearing, voice changes, difficulty swallowing, tooth decay, and postnasal drip. Then we have the Montreal definition of gastroesophageal reflux disease. He said it's a condition which develop when the reflux of the stomach contents causes troublesome symptoms and complications. Then we have esophageal reflux, as like I've said before, and we have extra esophageal symptoms, which are the cardiac and the respiratory. So what are the triggers that tend to worsen the symptoms of GERD? One, almost the among the triggers are high fat diet. So that's why when we are counseling patients, we counsel them on reduce fat diets, reduce fat food, citrus food, chocolate, caffeine, alcohol, and mint. Then it is the trigger this trigger is caused by stimulating the release of gastric acid as well as relaxation of the lower esophageal sphincter. Then when clicking this patient, what are the symptoms? What are the questions you ask? What food, which food, the food you ate? What time of the day did you eat? And which of these symptoms do you experience was a week? Then the other food that can mitigate symptoms. These are certain food that have been known to improve GERD, and they include vegetables like the leafy green, cucumber, oatmeals. The fiber helps to diet to absorb the acid, which now reduce the symptoms. Lean meat, egg white, and non-citrus food. The differential diagnosis of GERD includes esophageal neoplasm, caustic esophagitis, either from chemical burns, gastritis, peptic ulcer disease, bile acid reflux, and achalasia. The investigations we do include esophageal pH monitoring, which monitors the pH of the lower esophagus for acidity. It is a reliable means of diagnosing GERD. We have barium swallow, which involves ingestion of contrast medium and follow up with X-ray. Barium swallow helps in showing if GERD is caused by hiatus hernia. Then you can do complete blood count, esophageal manometry. Then number five is endoscopy. There is a gold standard of diagnosing endoscopy, which has over 95% accuracy. So this is a picture of endoscopy. What are the indications for endoscopy? The symptoms should have been persistent more than 5 years. Presence of mass, stricture, or ulcer on gastrointestinal barium study. Progressive esophageal symptoms in immune suppressed patients, dysphagia or genophagia. Then how do you treat? Treatment includes lifestyle modification and medication as well as surgery. So what are the lifestyle modifications? We have weight reduction, stoppage of smoking, reduce alcohol intake, regular small meals. You don't eat 3 to 4 hours before going to bed, and sitting upright after eating. Their medications includes antacid and H2 receptor antagonist, which includes cimetidine from famotidine. This helps to relieve symptoms in 50% of patients. Then other medications include proton pump inhibitors, which are omeprazole, rabeprazole, and they seem significantly more effective than um, H2 receptor antagonists for both symptom resolution and healing of this erosive esophagitis. Also effective in severe cases of GERD. So surgical treatment, there is laparoscopic insertion of band beads. Complications include esophagitis, anemia, esophageal stricture, and Barrett's esophagitis. Then we'll quickly talk about peptic ulcer disease. This is results from a break in the continuity of the mucosal lining of the stomach, first part of the duodenum, or occasionally the lower esophagus. While excessive gastric secretion plays a role in the development of ulcer, The primary cause of peptic ulcer is infection with Helicobacter pylori. This accounts for 90% of patients with duodenal ulcer and 80% of patients with gastric ulcer. Elderly people are prone to osteoarthritis with chronic use of NSAIDs, which predispose them to gastric ulcer. Excessive alcohol intake and smoking can have been implicated in ulcer development. Peptic ulcer disease consists of gastric and duodenal ulcer. Etiopathogenesis. Ulcers result when the balance between the aggressive forces and the mucosal defense are disrupted. Etiology. Helicobacter pylori infection, which accounts for about 80% of cases. The use of NSAIDs, tobacco smoking, stress, alcohol intake, Crohn's disease, Behçet's disease, and Zollinger-Ellison syndrome. This is a picture depicting the peptic ulcer disease. Then there are differences between, we have two types of peptic ulcer disease. We have the duodenal and the gastric ulcer. The gastric ulcer is rare before the age of 40 years, while duodenal ulcer is common among older age group. Acid secretion is normal in gastric ulcer, while there's hypersecretion of acid in duodenal ulcer. Pain is increased by food intake in gastric ulcer, while it is reduced by food intake in um, duodenal ulcer. And duodenal ulcer is of course worse at night. There's weight loss in gastric ulcer because the patients don't eat because of the pain, while in duodenal ulcer there's no weight loss. There's hematemesis. Hematemesis may occur in gastric ulcer, while in duodenal melinal stool may occur. What are the clinical features? PUD has may be asymptomatic if the ulcer is small. The major symptoms of epigastric are epigastric and nocturnal pain, which may be worsened or relieved by food or vomiting, depending on whether duodenal or gastric. Other symptoms include bloating, water brush, which is a mixture of saliva and stomach acid, which gives an unpleasant sour taste in the mouth, nausea and vomiting, loss of appetite and weight loss, hematemesis and melena. What are the signs? The pointing sign as epigastrum in 70% of cases of patients. This is the commonest sign. The patient will point and tell you that is where the pain is. Epigastric tenderness or discomfort. Then what are the signs of gastric outlet obstruction? We have projectile vomiting, abdominal distension, and weight loss. Investigations include Helicobacter pylori detection, urea breath test, endoscopy, which remains the gold standard in diagnosis of peptic ulcer disease. Then we have barium swallow. This is a picture showing barium study for PUD in duodenal ulcer and in gastric ulcer. The indication for endoscopy in PUD is age above 45 years, positive family history of gastric ulcer, cancer, presence of alarming symptoms, which includes melena or hematemesis, that's bleeding, perforation, patient present with severe pains, obstruction, patient present with vomiting, malignancy, patient present with weight loss. The goals of treatment is to one, eradicate the H. pylori infection, to relieve the pain, to heal the ulcer, to prevent recurrence, and to prevent long-term complications, and finally to cure. The treatment, like I mentioned before, it is lifestyle modification and medication. The medications are antacid, H2 receptor blockers, proton pump inhibitors, and surgery. Then the first line medication in the treatment in the eradication of H. pylori is one, we have the triple therapy where the proton pump inhibitor is used twice daily, either omeprazole plus clarithromycin 250 milligrams twice daily, and metronidazole 500 milligrams twice daily, or proton pump inhibitor twice daily, that's omeprazole 20 milligrams BD plus clarithromycin 500 milligrams twice a day, and amoxicillin 1 gram twice a day. Complications of peptic ulcer disease includes gastrointestinal bleeding, perforation, gastric outlet obstruction, gastric cancer. NSAIDs related ulcer. The risk in NSAIDs associated ulcer is increased by 3 to 4 times. It is commoner in patients on chronic use of NSAIDs for pain relief. So when you are collecting these patients, you also ask them for the job that they do. Some jobs require some people to take pain relief every day. So you ask them for the job. And women are more affected and people above 60 years of age. This is associated with gastric acid hypersecretion, anti-secretory therapy, and antibiotics use. Women tend to use more of antibiotics than men. Then the management of NSAIDs includes involve in discontinuation of NSAID being used for the substitution for a less toxic agent like COX-2 inhibitor. Acid secretion suppression can be achieved with proton pump inhibitor or a high dose histamine, H2 receptor blocker, and or an antacid. If NSAID cannot be avoided, then mucosal protection is beneficial using misoprostol in combination with the NSAID. Then Zollicalcisin syndrome is a triad of severe PUD, gastric acid hypersecretion, and non-beta cell gastrin producing pancreatic tumor. Average age at presentation is 50 years. Men and women are equally affected. It is mostly due to gastrinomas. 60 to 80% of these gastrinomas are malignant, and the low pH of seen in Zollinger syndrome predispose them to have vitamin B12 malabsorption. Most common presentation is bulbar ulceration that fails to heal. Most ulcerations in Zollinger syndrome are H. pylori negative. So when you do a H. pylori test for patients and it's negative, that does not rule out Zollinger syndrome. Though the initial treatment is with PPI. Patient presents with epigastric pain, chronic diarrhea, which is watery, upper GI bleeding, which is a complication, malabsorption, and refractory peptic ulcer disease. Diagnosis is made by having a serum gastrin which is greater than 1000 picogram per ml, basal acid output which is greater than 15 milli equivalents per hour, secreting provocative test which is gastrin rise in greater than 200 picogram per ml above the basal level. There's endoscopy, CT MRI, and somatostatin receptor um, scintigraphy. Treatment includes proton pump inhibitors. Chemotherapy is used in this case because of the gastrinomas that grow, and which I said 80% of them are malignant. We use 5-fluorouracil, cetolizine, doxorubicin are used. Interferon alpha. Then we have refractory radio frequency ablation, then surgery. What are the roles of family physician? We as caregivers, we are tasked with attending to patients with acid-related diseases. It's a case we see or we see almost every day in the general outpatient clinic. So we are the first point of contact, and we are to help them prevent morbidity and mortality. We give adequate information on disease type, presentation, management, and complication. The family physician also manages the patient's resources for the best outcome. We coordinate referral to appropriate specialties for further evaluation and follow-up. Then we also do research. In conclusion, acid peptic disorders help has been largely studied in recent times, and the general impression now is that it is essentially an infectious disease. The orientation to management has therefore changed remarkably. Endoscopic studies have also widened the scope of knowledge regarding this condition. Arising from all the above, family physicians are currently better placed to manage acid peptic disorders in their practice as they present. Thank you. Here are my references. Thank you for listening.